In this chapter, we're going to distinguish between primary immunodeficiencies and secondary immunodeficiencies. Then we're going to look a little bit closer at some of the primary immunodeficiencies. We're going to talk about the defects that are present in a couple or few of the immunodeficiency diseases, and we're also going to mention what laboratory testing is appropriate for these patients. And this picture really doesn't have to do with immunodeficiency diseases, but I just stumbled on it and thought it was cute and had to fill some space. It's kind of self-explanatory, but immunodeficiencies are disorders in which a part of the immune system is either missing completely or dysfunctional. It leads to the ability to, or the decreased ability to defend against infections, and it also makes these individuals more susceptible to developing cancer. We've learned previously that the immune system is an effective anti-cancer mechanism, because most time when cancerous cells form, the immune system gets rid of them. So primary immunodeficiencies are the genetic ones, and that can be X-linked, autosomal recessive, autosomal dominant. All aspects of genetic defects are included. These are going to be present at birth, but depending on the deficiency and the severity of the particular deficiency, it may not be detected until later in life. Secondary immunodeficiencies are acquired as a result of other conditions such as HIV, autoimmune disease, malignancy, or immunosuppressive therapy. I think it makes perfect sense that any aspect of the immune system can be affected. So if there's a problem with the humoral immunity, we're likely to see defects in the B cells and or the T helper cells. These people have an increased susceptibility to bacterial infections, especially sinusitis and otitis media. If the problem is within the cell mediated immune system, we're often talking about T cell deficiencies, and this leads to, in particular, an increased susceptibility to the intracellular pathogens. So all viruses, some bacteria, some fungi, etc. And when the innate immune system is affected, it's typically neutrophils and or macrophages that are the problem, although there can be complement issues as well. Now, there's a whole lot happening in this illustration, and you do want to go to your book and digest what is going on, what they're trying to show us. Don't try to memorize, but I will point out that it does show you specifically where certain immunodeficiencies affect the system, and we're going to talk about a couple of these. So like DeGeorge syndrome and some other ones. So, but basically the big picture in my mind of this graphic is to point out that the system is complex, and in most cases we've got A leads to B, which leads to C, da 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 da. Okay, so that something has to happen first, and then the next thing, and then the next thing. And so anytime we have this kind of complexity and this kind of dependence on multiple steps occurring, the problem can occur anywhere. And so once the problem occurs, then if the location of that particular problem is upstream from a particular immune system function, then that function is going to be affected. Thinking just about primary immunodeficiencies, your book lists even more categories than this, but so combined immunodeficiencies usually mean that both the cellular and the humoral components are affected in some way, shape, or form. There's some immunodeficiencies that are principally antibody problems. Some of them have to do with regulatory issues in the system. Some of them have to do with the ability of the phagocytes to do their job, defects in the innate immunity, autoinflammatory disorders, and complement deficiency. So again, this just points to the fact that the complexity of the immune system is immense, and so a million and one different things could go wrong and cause a disease. There are a number of different types of primary antibody deficiencies. What I particularly like about these is that most of them are very well named to help us learn what they are. So in A gamma globulinemia, the individual has low to no serum immunoglobulins. It's a genetic defect, has to do with the B cell maturation series or issues with interactions between B and T cells. Can involve all of the isotypes or one subclass of one type. X-linked Bruton's tyrosine kinase or BTK deficiency. This is the one that is kind of aptly named if you know that BTK is a particular enzyme that they're deficient in. What happens with these individuals is, again, in B cell development, and so a lack of mature B cells is noted in the blood. These are treated with gamma globulins, routinely given. Passive immunity in the form of this pharmaceutical product referred to as gamma globulin, made of the antibodies of a large number of humans all pooled together. Common variable immunodeficiency, as you might guess, that's a very heterogeneous group or variable, can be congenital or acquired. Symptoms usually begin a little bit later in life, although sometimes when these individuals present and they give their history, going back through the history, they're going to see that maybe there were some clues back there, but at the time they were occurring, it just wasn't enough to really raise any eyebrows. So in these disorders, the B cells don't mature into plasma cells, and can happen because of B cell or T helper deficits. Treated with gamma globulin. There's transient hypogammaglobulin of infancy. Basically, these infants are a little bit slow in developing their antibody production. So, as the name suggests, it's transient. They grow out of it as they finally have their B cells mature into T helper cells. Selective IgA deficiency. These people have low levels of IgA, apparently because of impaired differentiation to IgA plasma cells. If you thought about this and you think about where IgA exists, secretions, and you think, well, if they don't have these functioning antibodies in their secretions, are they going to be more prone to getting things like respiratory infections? You betcha. They may also be asymptomatic. It just depends on how low their IgA levels are. They may also have issues with allergy and autoimmune situations. And lastly, IgG subclass deficiencies, where we know that IgG has 4 subclasses, and it may be one or more subclass only that is affected. So by and large, the takeaway here is, in large part, it depends on how severe the deficiency is. Often people can be deficient, but not to the point of leading to symptoms. If they are, since they're missing antibodies, often we can give them the antibodies that they need to stay healthy. Combined immunodeficiencies are a group of complex immunodeficiencies. They affect both T cells and B cells, so they affect both cell-mediated immunity and humoral immunity. Possible treatment is bone marrow transplant, Clearly, they're going to have some major issues without having either aspect of their immune system functional. So the best we can do for them at this point in time is to give them functioning bone marrow from another individual. Severe combined immunodeficiency disease, or SCID, is also a group of disorders depending on specifically what gene is altered in these individuals. These are very serious. These are individuals who are born with essentially no functioning immune system. Um, you may have heard of a movie that was made, I think, in the 1970s called Boy in the Bubble. It was with John Travolta, and the main character was this boy who had to spend his life in a plastic enclosure, a bubble, if you will, and be in a completely sterile environment. And the picture you're looking at here is an actual one of these devices. You know, that boy has to live in there. Anything that's passed into him, whether it's food or clothing or a toy or anything like that, has to be sterilized first so as not to introduce any organisms into his environment, because he would have no way to fight infection. These individuals can be helped today with successful bone marrow transplantation, and they are continuing to work with gene therapy to see if they can make headway with that so that these individuals can have a quality of life. In former years, their lifespan was generally very short, even with the utmost care being taken to keep them in a sterile environment. That's something that's very difficult to do in reality. Wiskett-Aldrich syndrome is a rare X-linked recessive primary immunodeficiency. It's characterized by the triad of the immunodeficiency plus exa plus thrombocytopenia. It has defective T cell function, and so when the T cells aren't working, you end up with deficits or problems in both cellular and humoral branches of the immune system. Interestingly, the decreased levels of different classes of antibodies can vary, but most typically they have diminished IgM, normal IgA and IgG, and increased IgE. This is typically lethal in childhood, cause death, typically infection, hemorrhage, or malignancy. An interesting aspect is that these children lack ABO antibodies, and in the past that was often used as a clue as to the diagnosis. DeJoy's anomaly is abnormal development in the third and fourth pharyngeal pouch in embryo, and this affects the development of the thymus. There's, like most of these, there's a number of different specific chromosomal defects, but in most of the kids with this, they have a deletion in chromosome 22. It results in the underdevelopment of the thymus and, of course, then decreased T cells, mental retardation, hypoparathyroidism, which leads to hypocalcemia, cardiac abnormalities, and they do have a rather distinctive set of facial features, including a small jaw. Their ears are low set and often folded over, hooded eyes, and something that is sometimes described as fish mouth. It has to do with the development of the area above the top lip. And there's a range of severities in different individuals, but they all suffer from viral and fungal infections, some of which are extremely severe and life-threatening when the child is severely affected. The next illness we're looking at is called ataxia telangiectasia. That's a tough one for me to pronounce. I'd much rather say Lewy bodies syndrome. Telangiectasis is a term that means capillary swelling, and that leads to the red blotches on the skin. The ataxia portion of the name refers to an irregular gait or an irregular walk that occurs in people with this disorder because it also affects the nervous system. It is a rare autosomal recessive syndrome. Often there's a mutation in chromosome 11 that affects gene rearrangement in the T and B cells, results in a low number of T cells and a defective antibody response. It is severe. It does affect both the nervous system and the immune system. Individuals with Lewy bodies tend to die in early adulthood due to pulmonary disease or malignancy. Chronic granulomatous disease, like the others, is a group of disorders inherited as X-linked recessive or even an autosomal recessive, but ultimately causes a defect in phagocytic function. And in general terms, the phagocytes can engulf microbial organisms, but once they're inside, their biochemistry is altered to the point where they can't kill them. So these microbes are then free to continue multiplying within the phagocytic cell. In the laboratory, we can diagnose this with a test called the nitro-blue tetrazolium test, the dihydrorhodamine test, which is a version of flow cytometry. These people can be offered some relief by continuously taking antibiotics to prevent the infections. Now, the reason they develop the granulomas, which are characteristic of the disorder, is that these infected cells stimulate chronic inflammation, and the body responds to that by trying to wall off the area, try to sequester it from the healthy cells. And so the result of this chronic inflammation and this walling off process is a granuloma. Now that you're aware of the complexity of the complement cascade, you can probably predict that any number of things can go awry in that cascade and lead to some sort of a complement deficiency. Most complement deficiencies are inherited as autosomal recessive. In the grand scheme of things, the person who has a deficiency of C3 is in the most trouble. And we will have a case study on this too. And one of the questions on the case study is, why are the C3 deficiencies the most serious? And so I'm sure with just a little bit of thought, you can determine why the prognosis is worse for people with that issue. If an individual has a deficiency in the earlier complement components, the effect may be different, may be a much less severe, and it may be these people even go undiagnosed, depending on kind of the luck of the draw, what they're exposed to, and how well the other components of their immune system are able to fight off infection. It is interesting that people that have C9 deficiencies, which of course is one of the last complement components, and is responsible for poking the holes in cell membranes for the MAC. These individuals suffer quite a bit with Neisseria infections, and that leads me to believe that the organism Neisseria is probably the MAC is the only tool in our toolbox in order to get rid of Neisseria. So if you're missing the tool, then those types of infections are going to plague you. Screening for a suspected immunodeficiency really begins with the patient history. And typically these patients are going to present with an abnormal level of infections that makes people start wondering, is the immune system competent? So of course a CBC and a white cell diff may have some value in terms of the number of lymphs present. Measuring serum IgG, IgM, IgA, and also the subclass levels can be beneficial. We can look for those ABO antibodies, which should be present in all normal individuals by the age of 2. We can immunize the individual and then check their antibody titer a period of time after the vaccination to see whether they've developed antibodies. We can do delayed hypersensitivity type skin reactions, similar to what we did for the allergy tests, but we are doing them not looking for allergies this time around, but rather to see if the individual can mount a response. And usually they'll use antigens that are very common in the environment that most of us have been exposed to. And so, the thought is they've probably been exposed and they should be able to mount this cell-mediated immune response. CH50 assays, if we think there's a complement issue. DHR assay, if we believe there may be a problem with neutrophil function. Flow cytometry can be very useful in confirming immunodeficiencies. This graphic up here is really small, and of course you can't see it. I didn't bother to try to blow it up on this slideshow because it's really difficult to read even in your textbook. But do go to your textbook and kind of process those results. And when you go through everything, of course these are cells that have been separated by their CD markers, you'll see that these results demonstrate that this patient has no cells with CD19 marker on them, and CD19 is what we find on B cells. So this individual has no B cells. We can do genetic testing, and interestingly enough, they don't necessarily use genetic testing to confirm this diagnosis. We can do that otherwise without the genetic testing, but what they may do is test family members to see who is at risk, and they may want to do some genetic counseling for individuals that are contemplating having children, and what are the risks for their offspring and things of that nature. And then the other group of tests are mitogen assays. Now, a mitogen is a chemical that stimulates cells to proliferate. So we've got different mitogen tests that will stimulate either T cells or B cells, and then we can, after applying this chemical, which should stimulate them, we can assess whether the patient's cells were stimulated to see if there's a problem with cell proliferation. And of course, we've still got the old standards. We can do quantitative measurement via nephelometry or radioimmunodiffusion. We can perform serum protein electrophoresis and or immunofixation electrophoresis. What we're starting to see is the use of some routine newborn screening tests, and one of them is called TREC, and the TREC is the acronym for T cell receptor excision circles. Individuals who are not capable of forming these, when we detect them, we can learn that these individuals are going to have a T cell deficiency such as SCID, and so they reflect the number of functional T cells in these newborns. If you know anything about newborn screening, in some states we test a dozen or more various components of a newborn's blood before the child leaves the hospital. This is done with a heel stick, and the blood is applied to various circles on a filter paper card, and then the blood on those circles is used to run a whole battery of tests. Let's summarize some of the key points of this chapter. Immunodeficiencies can be considered primary or secondary. The primary immunodeficiencies, which is the ones we looked at in this chapter, can affect humoral immunity, cell-mediated immunity, or components of the innate defense system. Antibody deficiencies are characterized by low levels of serum immunoglobulins. They can be caused by defects in B cell maturation or in defective interactions between B and T cells. Antibody deficiencies include BTK deficiency, that's the one called Bruton's A-gamma globulinemia, common variable immunodeficiency, transient hypogammaglobulinemia of infancy, selective IgA deficiency, and various Ig immunoglobulin subclass deficiencies. Combined immunodeficiencies are complex. They involve T cell defects that can affect both cell mediated and humoral immunity. These combined immunodeficiencies include SCID, Wiskett-Aldrich syndrome, DeJour's anomaly, and ataxia telangiectasia. Chronic granulomatous disease is a group of disorders affecting the neutrophils' oxidative burst. Patients with CGD have decreased NBT and DHR test results. Complement deficiencies are autosomal recessive disorders that can affect the early or the late components of the complement system. Initial lab tests looking for immunodeficiencies include CBC and DIF, serum immunoglobulin levels, isohemagglutinins, the antibody response after vaccination, delayed hypersensitivity type skin reactions, and the CH50 for complement activity. Confirmatory tests include genetic testing, T and B cell mitogen tests, evaluation of the immunoglobulins by electrophoresis. Tregs are T cell receptor excision circles that are produced during T cell gene rearrangement, which reflect the number of mature T cells. Newborn screening for Tregs is mandated by many states to detect T cell deficiencies such as SCID. And with that early detection, we can immediately take the appropriate actions to protect these newborns from infection. This might be a good time to remind ourselves that number one, we're thankful for our actual military and all they do for us as a country, as well as being thankful for our internal military system, our immune system that routinely keeps us from getting infection and routinely prevents the development of cancer.